Everyone, this is Dr. Jason Profetto. I'm the chair of clinical skills and I'm doing the orientation for MF3. So if you're listening to this video and watching it, you have been selected as a resident preceptor to teach clinical skills MF3 at McMaster's undergraduate medical program. So before I start, I want to apologize because MF3 is a larger unit that's been reconfigured quite a bit from the previous year. So even myself, I find that I'm a little bit disoriented with the new content and the way it's set up, but I've done a bunch of reviewing to make sure I'm pretty clear on where we're going. But you may just hear me pausing to ensure that I'm saying things that are correct, okay? So this should last about 15 to 20 minutes, maybe closer to the 20-minute mark. I'm going to go through my orientation video or slideshow here, and then I'm going to show you the clinical skills guide, and we're going to go through a bunch of stuff, okay? So firstly, just for everyone who does not know, McMaster is a 3-year program. It's divided into pre-clerkship and clerkship, which is pretty standard for medical schools. And the pre-clerkship, which is important for you to know, contains several parts. So there's tutorials, professional competencies, clinical skills, and this is organized into 5 units, what we call medical foundations. So there's 4 medical foundations to start, so MFs 1 to 4. And then before clerkship starts, there's actually something called an integration foundation. So this is new. This is the new curriculum that we've been delivering since last August. The tutorials, professional competencies, and clinical skills are the main core pieces of the curriculum where most of the content is taught. They should complement one another. They're all considered mandatory and they cannot interfere in terms of scheduling. So these things are mandatory. Tutorials and clinical skills will have the same small group. So this is a group of roughly 7 to 8 students. Tutorials will be 3 hours per session and 2 sessions per week. So this happens twice a week. And what happens there is the students have a tutor. Whereas if you drop to clinical skills, this is small groups as well, 7 to 8 students, same as the tutorial. However, the leader of this group or the preceptor is a resident. So we have 2 residents per group. So clinical skills will be taught by co-resident preceptors, and these sessions are generally 2 to 3 hours in length and only once per week. The other big thing I want to draw your attention to is professional competencies. Professional competencies is also small groups, 10 students, but this is a longitudinal program. So Pro-Comp does not change for the entire pre-clerkship. It is the exact same group with no changes. There's 10 students. This is different than the tutorial groups, and these are 3 hours once a week, and this is every Tuesday morning. And what happens here is it's led by 2 what we call LFs or longitudinal facilitators. One is a physician and one is a non-physician or an allied clinician. Clinical skills. This is ironically enough, this simple slide is probably the most paramount in all of them. Clinical skills is really a focus on teaching the history and physical examination. There's going to be an introduction to diagnostic testing and what we like to call clinical or medical decision making. But the bulk of what needs to be taught is the history and physical examination. And we're going to get into MF3 shortly, but in MF1, this is where most of the focus is on respiratory and cardiovascular examination. MF2, you get into hematological stuff, some malignancy, as well as the renal unit. And in MF3, there's a focus on GI, endocrinology, and reproduction. So what will happen is that MF3 is the GI, endocrinology, reproduction. It's a 12-week medical foundation. There's going to be 1 session per week for clinical skills with the co-resident preceptors. That's what you're teaching. So these are weekly sessions. They're 2 to 3 hours in length. Everything is guided by our clinical skills manual. This has all the content and all the schedule information. I'll show you that in a second. And each group has 2 preceptors that you will already know about your group information, and you'll have 7 to 8 students per group. The focus is on teaching these clinical skills and practicing them as well. And I really emphasize this point because that's a very, very important take-home message. There's a bunch of different locations where clinical skills can be taught. The most popular one, I think, is the CSBL, the Center for Simulation-Based Learning. That's at McMaster Hospital. There is 1M and 1G. These are the two different physical locations in the hospital. They are on either side of the cafeteria. And this you can book online or through our administration. You can actually book rooms here. So it's pretty cool, and maybe most of you have seen the CSBL, but there's a bunch of clinical rooms, examination type rooms where you can go in. There's beds and there's materials and one-way mirrors and all sorts of fancy stuff. And you can see standardized patients in those rooms or teach clinical skills in those rooms. You just have to book them through the online or the admin. The other thing is that if you're in any Hamilton or McMaster associated hospital, you can teach clinical skills on the ward or in a clinical setting. I put here 2 community clinics like family medicine clinics, etc. As long as it's appropriate and you have permission from whoever the senior admin is. So I wouldn't just take a group of 7 or 8 students in the middle of the ICU and start teaching clinical skills. I would make sure that it's an appropriate setting, that you have a bit of space, that you've spoken to the patient or the family or the staff or whoever's there so that you can teach clinical skills. And if you ask around, especially to other people who are teaching, you'll get a sense of where in the hospital are the best locations. All the departments will also have information about where you can teach, where you can bring students, and that sort of thing. But these are some of the main locations that you can do this. When you teach clinical skills, it's very important that students get ample patient exposure. I'm going to repeat that because it's one of the main pieces of feedback we receive, that students don't get to see patients. One of the main things you have to do in clinical skills is introduce students to patients. This can be a combination of standardized patients, real patients if you find them in the hospital, the clinic, the emergency, or student colleagues. I'm going to make a comment on that in a second. And then there's also St. Peter's Hospital. So we have SPs. These are standardized patients. These are actual people that are trained to be warm bodies or standardized patients, or they can have simulated cases and they can do almost hold a script for certain things. If you want a patient that has Crohn's, you can book a standardized patient actually knows a history of Crohn's, so you can teach them. At McMaster, we have an SP program, and this is in the frequently asked questions too. So you can book your standardized patients through the SP program. It works great. You just got to give them at least a few days notice or whatever the specifics is. I think it's like 5 to 7 days notice. And then you can get the standardized patients. You can have them meet you at the CSBL and you can teach. It's a great experience. You can obviously teach on real patients, whether in the hospital, a ward, a clinic, family medicine clinic, etc. The only thing is anytime you are going to use real patients that are in the hospital, the healthcare system to teach, the consent and permission needs to be crystal clear. And often what happens is when a patient is relatively stable, the majority actually do like to participate in medical education. So you'll find that a lot of patients are quite enthusiastic about helping and teaching and participating as a standardized patient. Use your discretion, use your professional judgment to make sure that you're not misusing a patient or overusing a patient and that sort of thing, right? I'm going to jump down to St. Peter's Hospital. So St. Peter's Hospital is an extension of the Hamilton Health Sciences. This is where we have complex continuing care. And we are fortunate that there's a lot of patients there and there's administrative staff that will vet and filter the patient load to see who would be appropriate for participating in medical education through clinical skills. So if you contact St. Peter's Hospital admin, and the contact information is in your FAQ, you will be able to book however many patients, 1, 2, 3, whatever you need, and the admin will go around to make sure that the patient understands what's happening, how long it'll be for, what the time will be. The family or the patient or whoever will provide appropriate consent and give permission to do so, right? I also put student colleagues. So students can examine one another, but some schools actually have very specific policies on this. So for example, no abdominal exams, nothing around the chest or breast area, and obviously nothing in the region of the pelvis. But for example, if you were going to examine the hands or the arms or the legs or the feet or the head and neck, or do a blood pressure or listen to the lungs or the part of the precordial exam, Many would argue that this is appropriate. So at McMaster, we don't have a very specific policy. I would definitely recommend an opt-in as opposed to an opt-out. So it's not assumed that all students will participate in physical examinations. I don't think that's fair. And I think you really need to use your discretion. So if I was teaching the abdominal exam and I needed to use an abdomen that was exposed, I would not use a student, nor would I have students practice on one another. If I was teaching the peripheral vascular exam for diabetes, for example, and like showing how to use a monofilament on someone's feet, I think that would be appropriate if I had a student volunteer. If I wanted to teach how to do a blood pressure on a student, I think that is appropriate. And if I had to listen to a precordial exam, I would use my discretion whether or not examining the chest wall of a patient was appropriate or not. There's no perfect answers here. We have not had problems in this area. I would just recommend that you use your discretion. But as you can see, there's multiple avenues in which you can book patients. So content and agenda. So we have a clinical skills manual. It's very, very important that the agenda is followed in the clinical skills manual. There's week by week content and a guide that will show you what needs to be taught. It is imperative, paramount that this is actually followed. This document has been developed and revised over a number of years now. I think we started it back in 2014, 15, and then it really became something official. There's a copyright and everything on it. It is specific to McMaster. The students have their copy. You will have a copy as well. It is referenced and consistent with the AFMC Clinical Skills National Working Document, which means that everything that we teach in clinical skills at McMaster is consistent with what's taught across the country, meaning that certain things have certain levels of competency. A pre-clerk should know how to perform a blood pressure. A pre-clerk should not necessarily be proficient in performing a pelvic examination on a woman. That comes later in clerkship and in residency. So there's differing levels of that, and that document, the link is available if you're curious in the actual guide. And then you'll see too is that we've done a lot of work in the realm of integration of diversity and inclusion. So just a quick example here. When we teach the abdominal exam, I think many will appreciate this, that we often say the abdominal exam is taught, you have to lay on the table or an examination bed, and we will approach from the right side, etc., etc. But what happens when, for example, you have a patient that has advanced Parkinson's disease and they are unable to get on a bed, an examination bed, and lay down? For them to actually climb onto the table, it is unsafe or unfeasible. So what we have to do is understand that while we teach certain examinations in a normative fashion, there are many populations that do not fit that mold per se. So doing an abdominal exam on an individual in a wheelchair is a very good example of that. And then there's a lot of examples that come up in different realms. The four major areas that we try to focus on are people with disabilities, individuals from the trans community, and more globally speaking, LGBTQ considerations, individuals of different skin colors, skin tones, especially when, for example, you do the examination of a mole versus melanoma, or if you look at jaundice, how that will differ in individuals from different parts of the world, or different skin tones, or different ethnicities. And the last one was individuals with varying body habitus. So an individual whose BMI is elevated, how does that change, for example, McBurney's sign, or the ability to palpate a liver or a kidney or peritonitis, etc., right? And you'll see a lot of that in our actual clinical skills guide. Now, I'm going to bring you to the clinical skills guide for MF3. So this is the clinical skills guide. And what you'll notice is that this is actually still the draft, because we haven't finalized the final one for MF3, but it's coming up very shortly. It'll be the same. So there's a bunch of different introductory material in the editors, and then this is the big part that I want to show you. So MF3, there's going to be two main sections. There's the clinical skills. So these are all the different clinical skills that are actually taught. So if you go to, for example, let's do the adrenal examination. If you click on the hyperlink, it'll bring you to the adrenal exam. So both like the HPI, the history, what should be taught, different considerations around, cushingoid or hypocortisolism or different areas of endocrine adrenal pathology. And it'll go through all different things. We have included different tidbits from the Rational Clinical Exams JAMA series on statistics and how to apply different clinical skills to decision making, right? So you'll see that if you go to these hyperlinks, you'll get all the different examinations available. Okay. If you go to the weekly session guides, these are where the actual agendas come in. So you'll see that there's 12 sessions. This is week by week. And then this is chapter 13 to 22 because it continues from MS1 and MF2. And what we've had to do is we've broken up the clinical skills guide for this year because we're continuously developing this as we go, as this curriculum is new. So you'll see that when you go to the weekly sessions guide, you can see what we're going to be doing. There's going to be an introduction and overview of the abdominal exam. And then there's going to be a solid month where we go through a bunch of this is like the GI unit and nutrition unit. The first month is going through all the different abdominal exams like weight loss, diarrhea, jaundice, liver disease, abdominal pain, all of that. And then as you go down, this is where we start to get into, in the MF, we're getting into endocrinology in the next month. And you'll see the thyroid exam, the adrenal exam, the diabetic exam. But we also here really try to include other things as well. So we don't have a lot of stuff on pediatrics. So we've introduced, this was a couple of years ago, the newborn history, adolescent history. And then when you go down, this is going to be the sort of reproductive unit. And you see that we have the gynecological and sexual history and the obstetrical history. As well, it should be mentioned that it won't be taught here, but in MF3, there's also going to be an obstetrics clinical skills session outside of these clinical skills taught by the obs and gynae department. And they're going to go through like the different parts of labor, the different parts of a pap smear, a pelvic exam as well. Whereas this is going to be much more focused on the history. So it's going to complement one another. And then you see the last theme here is the dermatological week where we get into rashes a little bit. Now, if you remember, I said that we were going to do a bunch of integration, and we have some specific ways in which we're going to be connecting to professional competencies. So you'll see that there's different themes here that will tie into the actual week that we're talking about. So, for example, when we look at the gynecological and sexual history, there's going to be a pro-comp connection when we look at LGBTQ+, and how that connects to the gynecological history, right? So it's in here too, in the dermatological exams, patients with skin of color. And what happens is we're going to be very intentional about making sure that we focus on certain areas that are diverse and need to be included in how we teach these clinical exams. So I'm going to click on the introduction. When you see it here, like this is relatively short. See, like session 1's here, session 2's here. You'll see the specific items that need to be done, and I would just basically follow this along, right? There's a lot of interesting stuff here. There's tying it into some evidence-based medicine. When you teach the abdominal exam, does this patient have acute appendicitis? It tells you how to use it. It's focusing on the bottom line, how it relates to the abdominal exam that you're learning. And then as you go down, you'll see the different sessions and the different content that's included. I just want to make an example of, so here, pro-comp connection, food and housing insecurity. So this is actually looking at the newborn history and failure to thrive as sort of like a topic and how to teach doing that history and what to ask. And when you go back to the content, you'll find that content, that the things that need to be asked. And then this pro-comp connection, there's a little bit of reading here and some questions that can help stimulate discussion around clinical skills on this topic. If you go down, I want to get to an LGBTQ example. You can see there's a lot of stuff here. So this, we're going to be doing the gynecological and sexual history. And then there's some information on, encountering trans patients and how they present in all areas of medicine, and some discussion questions. for example, we've always been taught this. When you ask about sexual history, do you have sex with men, women, or both? And you can see that now that might be a bit of a problematic way of asking and not as inclusive as it could be, right? So there's different references and information about how to ask these questions. And the school was really committed to ensuring that where there are areas of diversity, we need to ensure that we're being very inclusive and thoughtful of how we're doing this. So you'll see many opportunities where these sorts of topics will come up. It's not meant to dominate discussions and take over the bulk of clinical skills, but there is a very direct intention that we are thinking about these things, that you guys have some stimulating questions to incorporate into your teaching and your learning and your practice when you're actually practicing on standardized patients or real patients. And then there's the dermatological case. So you can read through this a little bit. I won't go through this too much. But I just wanted to show you that. So the Clinical Skills Guide is very thorough. It has all the information that you need, and you can look through it when you have a chance. Now, a couple of things as we end off. We only have a few more slides here. There's going to be 2 sets of evaluations, mid and end of unit evaluation. This will actually happen through MedSys. One of the clinical skills preceptors will be contacted. It is very, very important that these assessments are done in a timely fashion. Do not procrastinate. Don't leave this for more than a couple of weeks because it'll start to affect our ability to reach accreditation standards. The other thing is that your evaluations in clinical skills will once they're completed, it will allow the tutor to complete their evaluation of the student the overall performance in MF3. I would strongly recommend direct observation and weekly feedback. It has to be regular. It has to come often. If you go back to the Clinical Skills Guide, you'll see that there's where are we here? So if you look, there's these things called the direct observation of clinical skills checklist. And it just gives you a sense of how to, if you want to use this as a guide, how to observe them, what to look at, give them some feedback so they have it written down as well. But the clinical skills evaluations should never come as a surprise. These should be done on a weekly basis. And then when you're giving formal feedback in mid and end of unit, there's no surprises, and it's just a consolidation of everything that's been said to date. If you think a student is really struggling, please let me know. I will help you through the process. It cannot be ignored. In medical education, we tend to minimize these issues a lot and sort of like sweep around them, but it needs to be addressed because if a student is struggling, it's very likely that they may struggle in the future, and it may affect their performance in clerkship and on licensing exams. So when a student is identified as struggling, we get involved, and as a result, we're able to remediate and help and offer additional services. Professionalism is a biggie. I think, I would literally leave it as vague as this, because when I say there's a dress code, there's some things that are very standard. For example, I don't think it's wise to be on a hospital floor with open-toe shoes. Like that's a standard. But you probably shouldn't be wearing shorts or ripped jeans or something like that when you're encountering patients. But whether or not, what the fabric of someone's pant is, or blouse, or dress, or skirt, or whatever, I don't think that's as important to be prescriptive about. There's a sense of what's appropriate and what's not. I always think that dress code can be a little bit tricky, but use your discretion, be open with people, make sure that you think people are presenting themselves in a professional way, the way in which they speak, the language they use, being polite and courteous, introducing oneself. So this is a delicate area, but an important one, and usually we do not have problems here, which is good. So what will happen in terms of scheduling is you have to schedule weekly sessions with your group. Remember, the sessions are 2 to 3 hours. They need to be usually in the afternoon or evening, and generally what happens for the bulk of groups is that clinical skills is scheduled between Monday and Thursday in the evening hours or late afternoon. So this has to be above and beyond your clinical duties. That's why you get paid to do this. You get a stipend for that as a result. There's going to be variability from week to week because residents generally have call schedules and they have to work around that. The students know that. I would try to avoid weekends or Friday nights if you can. Sometimes that does happen. Clinical skills is definitely considered mandatory, so students have to come. When you're being flexible and negotiating when you're going to be booking a clinical skills session, the only thing that can really interfere is other mandatory activities. So if students say, we have a volleyball game, an intramural game tonight, is it okay if we reschedule clinical skills? I hate to come down hard, but the answer is no. We have an interest group. The answer is no. So clinical skills is considered an important mandatory part of the curriculum they must attend. It's okay. Like, you can be flexible. If the students all have a really big thing that they want to go to and rescheduling from Monday to Thursday is not a big issue for you, that's fine. I just don't want to see that abused, especially given how busy our residents are. Everyone's going to be getting an FAQ sheet with frequently asked questions. It'll give you all the big information that you need to know. How do you get paid? What is St. Peter's Hospital? How do you book patients there? How do you book SPs? How do you get into the CSBL? Where do the evaluations come? Who do you contact? How do you get in contact with the MIN? All that sort of thing. So if you have any questions, you can refer to this. This will come as part of the package that you receive with this video. And then the other thing is that, students love clinical skills. Residents love teaching clinical skills. There's a huge role modeling and mentorship that happens in this way. Enjoy what you're doing. Be creative. Have fun. This is not meant to stifle your creativity. You should be able to use the clinical skills manual, teach it in the prescribed way, but still be creative and do different things for your students. At any point, if you have questions, please email me. We get questions every MF. This is a new MF. Like, the content, the way this is created is really new. So this is going to be GI, endocrine, and reproduction. It's a 12-week unit, so it's a big unit. Remember too is that you can split the teaching with your co-resident however you want. You can each take a week. You can both go to each week and just split up the group. If one of the residents is on call and can't make it, on vacation, whatever, the other one can take over it. Just work through as a team and see how the scheduling goes. We really appreciate everything that you do. We really appreciate your enthusiasm, and I really hope you enjoy the clinical skills. And again, this was for MF3, so if you have any questions, let me know. Thank you.